Please listen carefully.
Hello, Team Anaesthesia. Welcome to GasGasGas. This is the best anaesthetic science podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. Now, you might be in the gym right now, commuting, or ironing your scrubs, and there's no judgment here. GasGasGas will prime your brain for the monsoon of knowledge you need to imbibe. But regardless, the revision is eventually going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Now remember to check out the website, that's gasgasgas.uk. There are show notes there with all the detail, plus links to foundational reference papers and anything else useful I find for you guys. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello, and welcome to another episode of GasGasGas. I hope you've had a delightful first 2 weeks of March. It's finally something that could be mistaken for spring in deepest, darkest Yorkshire. But let's not get carried away with the sunshine. We're here to talk about pancuronium, that exceedingly commonly used neuromuscular blocking agent, which I'm sure is in everybody's anaesthetic room fridge. Why are we bothering to talk about it? Well, other than the fact that I just feel like you should, I should at least, you probably shouldn't, but I should, is because it is perhaps one of the first aminosteroid neuromuscular blocking agents that really made it to market. And we can learn a lot about today's aminosteroids from this one. So the ampule will be labelled Pancuronium bromide, and its brand name once upon a time was Pavulon. Where does the name Pancuronium come from? The name was derived from it being called a piperidino androstane curarizing onium. Who knows why they put onium on the end? Curare. Androstane is an important word there. I'm sure once upon a time, at the deepest depths of studying steroids at medical school and testosterone and all that sort of stuff, that you'll remember the word androstenedione, and that is because this molecule is based on a steroid hormone. Ultimately, the original attempt at aminosteroids was where they put an acetylcholine-like molecule onto either a 5-alpha androstane 17-one, rolls off the tongue, or 5-alpha pregnan 20-one, which is a synthetic androstenedione, and then later onto an endogenous steroid hormone. And when they were doing this mucking around, they found that it had a degree of paralysing activities, these fudged acetylcholine steroid molecules. Now, they caveated at the point in time that someone called Bucket, with 2 T's, noted that it had limited clinical value, but that these compounds presented leads for further chemical exploration, particularly the subsequent synthesis of our bis-quaternary aminosteroidal salts. And Bucket, Hewitt and Savage in 1967 paper pointing out a bunch of these different molecules, and one of them being pancuronium bromide, which they first synthesized in 1964. So this has been around since the 60s. This was an exciting time for anaesthetic pharmacological science. Nowadays, I don't think we quite do as much anaesthetical science, drug discovery. Everything we've got is quite good, except for the odd thing here or there, like Sagamidex, a future episode. In amongst all this joyful reading of papers that have been scanned because they were kind of typed as opposed to printed once upon a time, I stumbled across where Bowman's principle actually derives from. Now, you remember Strathclyde University were heavily involved in anaesthetic science, particularly neuromuscular blockade, where they developed atracurium. So Professor Bill Bowman of Strathclyde University spent a lot of time fiddling around with neuromuscular blocking drugs. And this is where the term Bowman's principle comes from, because he posited and demonstrated that the potency of a drug is inversely proportional to its onset time, because you have to give more of the less potent drug. Bowman's principle. A bit more history there. So, back to pancuronium bromide. It is a single stereoisomer. It is presented as a clear and colourless solution that must be refrigerated, with 4 milligrams classically in an ampule. It is acidic. Apparently it has a bitter taste, if you're going around tasting paralysing drugs. and it's quite a heavy molecule in the grand scheme of neuromuscular blocking drugs. It's heavier than rocuronium at 732 grams per mole. Mechanism of action of pancuronium, you've guessed it, it is a competitive, non-depolarizing neuromuscular blocking drug. It works at the neuromuscular junction, antagonizing the action of acetylcholine at the nicotinic, remember that's the N2 receptor, situated on the postsynaptic membrane of the skeletal neuromuscular junction. But it also has action on the presynaptic membrane. Remember, this is the retrograde modulation of that motor neuron by acetylcholine. When it's released into the neuromuscular junction, some of that acetylcholine goes back and tickles that motor neuron ending to say, hey, I've just had to contract. You need to mobilize some more acetylcholine and get those vesicles nearer that synaptic cleft, ready to be released. If another signal comes, don't be lazy, get to work, as a bit of a feedback loop. This is where fade comes from. And pancuronium does have a action in the ganglion blocking department. Ganglion, really we're talking about parasympathetic nervous system here, and it will bind to and impair the function of your parasympathetic nervous system. That means that you tip towards a bit more of a sympathetic drive, leading to an increase in heart rate, blood pressure, and cardiac output. How do you dose it? If we think, well, there's only 4 milligrams in a vial, and generally speaking, a vial of drug is about 1 adult dose, here and there, depending on the drug of choice, of course. I wouldn't really classify a 4 milligram ampule of noradrenaline as 1 adult dose. That would probably be quite problematic, but 4 milligrams of ondansetron in an ampule, certainly 1 adult dose. So the intubating dose of pancuronium is 0.1 milligrams per kilo, taking 2.5 minutes to get you to something that could be mistaken for intubating conditions, and peak effect is about 4 minutes. Do you need a maintenance infusion? Well, not really, because pancuronium lasts for a really quite long time, at least 90 minutes, give or take. If you're a cirrhotic patient, even longer. So it was a bit of a fire and forget. They're going to be paralysed for an hour and a half, put your feet up. Great for a long case, not so great for a quick ENT procedure. So the important thing to think about with a competitive non-depolarizing neuromuscular blocking drug that lasts a really long time is that the degree of recovery takes a really long time. So instead of maybe seeing someone snap from a scant bare 4 twitches with fade to barely any fade, that is a longer journey. But if you're seeing 4 twitches and you're tempted to reverse the patient, you might find yourself in a situation whereby you've made it all better, the neostigmine wears off, and actually that pancuronium is still lurking, wanting to fight it out with the acetylcholine in the neuromuscular junction and lead to recurarization. So the longer a drug lasts, the longer that period of recoverable but might fall back to being a bit paralysed lasts. So the lowest paralysing dose in a non-human model is actually 1/10 of the intubating dose recommended, so 0.01 milligrams per kilo. Now, the wonders of historic science have led me to an exciting discovery. And you know, I've taken the mickey several times saying, well, if you drink this drug, it probably doesn't do anything. Well, they did indeed give mice pancuronium orally. Now, how much pancuronium per kilo do you have to give a mouse orally to paralyse it and thus doomed? You need to give it 21.9 milligrams per kilo. Now, obviously a mouse is quite small and less than a kilo, but that is quite a lot more pancuronium for it to be orally absorbed and cause mischief. So, rocuronium is also an aminosteroid, although with a greater liver metabolism. So we could infer that a lethal dose of pancuronium in an adult might be 1.5 grams of pancuronium, which, you know, that's like 400 ampules or something stupid of pancuronium. Someone would probably notice, and there probably isn't enough in the hospital. It might, if you fudge the maths and not consider hepatic metabolism of rocuronium, mean that you might need to consume perhaps 120 ampules of rocuronium to paralyse yourself orally. Now, I've not tasted rocuronium, and I don't recommend you should either, but there you go. Maybe they do have some oral effect after all. Anyway, that was very exciting for me. You're probably sat there thinking, James, I'm trying to pass this bloody exam. Stop talking about eating rocuronium and pancuronium. You're right. Let's move on. So, side effects of pancuronium, like most other neuromuscular blocking drugs, except for suxamethonium, it's pretty hecking stable. It causes an increase in heart rate and blood pressure, and therefore a bump in cardiac output due to this vagolytic effects, ganglionic effects, where it goes off and binds to N1 receptors, not N2 receptors. Very unusual for it to cause histamine release, therefore very unusual for us to see bronchospasm with it. It doesn't muck with the systemic vascular resistance, particularly unless you're very unfortunate to see some histamine release. And naturally, it obliterates the rate and depth of breathing because it paralyzes you. As with other neuromuscular blocking agents, there are conditions which increase the potency of these drugs, such as co-administration of magnesium, gentamicin, volatile anaesthetic agents, lithium, etc., covered in a previous episode. The real chief problem with pancuronium is it hangs around for ages, but it was a choice agent in cardiac anaesthesia where you might be doing a 6 or 7 hour case every day, and therefore, why not make your life easier by just giving them some pancuronium and having a nicely paralysed patient for at least an hour and a half? So, pancuronium pharmacokinetics. Absorption, I've written not applicable, because it isn't really, but we know that you could achieve some paralysis with oral pancuronium. The onset time is probably not terribly compatible with intubation, though. Distribution, pancuronium. So, you would expect, like rocuronium, which is another aminosteroid, like atracurium, benzyl isoquinoline, its volume of distribution is quite low, and it is 0.2 litres per kilo. It's chiefly water-soluble, doesn't really soak into those fat stores. Its volume of distribution is higher in a cirrhotic patient, and bear in mind that, remember, these are cirrhotic patients from the 1960s and 70s, whereby our treatment modalities were perhaps not so great at managing the water content of someone with less than effective liver function, but ultimately they required a higher dose to achieve intubating conditions within a sensible period of time. Metabolism. Like other aminosteroid drugs, it undergoes a degree of liver metabolism, although not quite a lot. 30 to 45% of the molecule is metabolized by deacetylation, and then it's excreted in a manner through the biliary system. Now, one of the metabolites, a quarter of it, is converted into 3-hydroxypancuronium, and that has 50% of the activity of pancuronium. So we've got an active metabolite. But we now should be thinking, well, only 30 to 45% is cleared by the liver. So actually 40 to 50% is excreted in the urine, and about 80% of the content that ends up in the urine, 80% of it's unchanged, so it's still pancuronium. So you whiz out about half to 40% of the molecule unchanged. Half-life, 69 to 160 minutes, and double it if you've a cirrhotic patient. So if you are somehow in a situation where you're doing an extensive coronary artery bypass or some other cardiac mischief in a cirrhotic patient, which you probably wouldn't do, that dose of pancuronium might start to last you the whole case. And its clearance is 1.1 to 2.2 mils per kilo per minute. Exciting. So, pancuronium, that was a whistle-stop tour. Anyhow, time for a brief mention about the sponsors of GasGasGas, Teach Me Anaesthetics. These guys are behind an excellent single best answer question resource. Firstly, I took the joyful, challenging, and intermittent bashing through their 1100 plus questions, which they have written for the FRCA primary exam. Now, I secretly loved it, and there are plenty of questions to test your knowledge. When I was studying for the FRCA primary, it did not exist, but there were other packages online. These cost a lot more, and they didn't really seem to reflect the content of the exam. Whilst doing them, I came across rehashed MRCP questions, which was not terribly inspiring and left me pretty cheesed off. Whereas these single best answer questions have been built from the ground up. They have not sniffed an MCQ in a past life. They are based on the anaesthetic science you need to know, and there are explainers with all the questions, so it builds your knowledge as you work through them. There is a multitude of ways you can study these questions. You could choose to do a random battle with 1100 plus questions, or split them into subject area. You can go back and redo the ones you've gotten wrong. It's very malleable. So if you've been thinking about which question resource you might want to get your hands on for the exam, you shouldn't really look any further than Teach Me Anaesthetics. If you reckon it's for you, all the links to Teach Me Anaesthetics from GasGasGas are affiliate links. So if you're signing up through one of those, you're helping to support GasGasGas. So if you think you're going to go for it, click a link with me. You know you want to. You'll not only be supporting your exam preparation, but you'll be supporting your 100% favourite Tell Your Nan Over Sunday Lunch podcast, which is, of course, GasGasGas. Okay. How much more can we possibly talk about neuromuscular blocking drugs? Well, seeing as they're very commonly used, plenty. I'm sure you've come across, someone's mentioned, or you've seen in some esoteric literature that you've been poring over, a mention of type 1 and type 2 neuromuscular block. Now, this really did confuse the bejesus out of me, because I hadn't heard that expression before. It's important that we just cover it so that if someone mentions it, or it perhaps comes up in an exam when someone's using maybe a slightly awkward term to test you, and it refers to the behaviour of the neuromuscular junction when tested with a twitchy box, dependent on the class of drug it's exposed to. So a type 1 block is a block associated with the administration of suxamethonium, and you've tested that neuromuscular junction with the twitchy box when you've given a dose of suxamethonium. And a type 2 block, sometimes described as a desensitization or dual block, another thing to confuse the heck out of you, is generally associated non-depolarizing neuromuscular blocking drugs. But it would also be important to say that a type 2 block demonstrates fade, whereas a type 1 block does not demonstrate fade. That's perhaps one of the key differentiators. The other foible, interesting or not, is that if you give someone repeated doses of suxamethonium, you shift from a type 1 block to a type 2 block. And we're going to explore that too. Now, I don't know how many people have attached their twitchy box to a suxamethonium paralyzed patient, but I have. Mainly because I was just wondering, when do they get their twitches back? Are they in that cohort of people who are paralysed for a little bit longer from suxamethonium? Just for curiosity. I can't tell you I found anyone who was a bit more paralysed than you would otherwise expect. But when you do twitch them, you won't see fade. You'll just see a diminished response and a similar amplitude of contraction with each energy delivery. Righty-ho. Type 1 depolarizing block. Suxamethonium is the only drug we use in this category. And we know that suxamethonium binds to the post-junctional nicotinic acetylcholine receptors and acts as an agonist, i.e. it activates those N2 receptors, causing depolarization. This depolarization leads to fasciculations because that depolarization is slightly disordered. It's not all the muscle contracting all at once, it's all the bits of the muscle that have achieved a suxamethonium concentration at slightly varying times because of blood flow across the muscle, leads to fascicles depolarizing at different times, and you get that twitchy phase, and then paralysis. It does give you a lovely endpoint of when they're paralyzed, and it does work really quickly, faster than rocuronium, really. However, it is not broken down in this cleft, in this neuromuscular junction, because the acetylcholinesterase there can't touch it. Therefore, suxamethonium floats around in there until it is cleared back to the plasma. Now, you are right in remembering that a dose of suxamethonium that you give, quite a bit of that is cleared in the plasma before it actually makes it to the neuromuscular junction. But once it's soaked into the neuromuscular junction, the drug that is there works. It has to diffuse back out for it to be cleared. This is because plasma cholinesterases can knock it on the head, whereas acetylcholinesterase in the neuromuscular junction cannot. So we're in a situation where we've got a neuromuscular junction flooded with suxamethonium that's falling off receptors, rebinding to receptors, and this keeps the resting membrane potential in an awkward situation whereby it cannot repolarize and be ready for the next signal because some acetylcholine's binding, some of it's floating off, someone's binding to something else, until it eventually clears enough that it can repolarize. As this suxamethonium eventually clears out, you find yourselves in a position where you can trigger a bit of a contraction in the muscle, but not a lot. This is because some of our sodium channels, our nicotinic acetylcholine recepting sodium channels, are blocked and some are not. Therefore, if you can deposit some acetylcholine into the neuromuscular junction, some of it will make it across, some of it will bind to these now accessible receptors and trigger a degree of contraction. However, the amount of acetylcholine in the neuromuscular junction released by a action potential going down that motor neuron, that amount of acetylcholine is the same, but it's working against a barrier of suxamethonium, so to speak, so it will only achieve the same effect each time. No amount of increased acetylcholine in the neuromuscular junction will increase the amount of muscle you can trigger a contraction in, because it's not a competitive situation. That suxamethonium is bound. and it won't unbind just because there's some acetylcholine knocking around. So unlike a type 2 block or a phase 2 block or whatever else, a dual block, a desensitization block, all the different names for the same thing, you won't see fade. And even if you do a tetanic stimulus and then do, a post-tetanic count, you won't see fade. You'll just see the same meek contraction each time that will get better. You'll get more of a contraction as the succinylcholine slowly clears out. A type 2 block. This is different, as you would expect, to type 1, and resembles the block produced by non-depolarizing agents, despite this block being caused by a depolarizing drug, and might make your head hurt a little bit. So, what do you see? You see a fade across the train of 4, a tetanic fade, and post-tetanic potentiation. That is, you give them fire off a train of 4 and then immediately fire off another train of 4. The second, you will probably see increased amplitude of contraction compared to the first. You have potentiated the neuromuscular junction. This is what you see with non-depolarizing competitive neuromuscular blocking drugs like atracurium, rocuronium, mivacurium, etc. I'm not going to come out and tell you, we know exactly why this happens, because it doesn't appear that we do. But actually, if you drill down into most things in medicine, we've got a bit of a grip of it, but actually when you start getting into the edge cases and looking at the minutiae, you think, there's something here that we're not quite grasping. So don't stress about it too much. The crux of what we do know is that the nicotinic receptor that the succinylcholine is tickling transitions from being depolarized, i.e. open, allowing sodium through it, depolarizing the membrane, to a desensitized state, i.e., it's hung up its coat, it's had enough. It's closed, but occupied by the succinylcholine. So it becomes just unresponsive to further stimulation. Because it's closed, those sodium-potassium ATPases that are, very busy little fellows can start getting that muscle creeping back towards a repolarized state. So as some of that succinylcholine clears out of the junction, but some of that succinylcholine is just bound to now receptors that are just not going to do out, you find yourself in a situation where acetylcholine, delivered to the neuromuscular junction by an action potential down a motor neuron, can trigger a contraction. Now, why does it cause fade? Don't think anyone's particularly clear on that. But what is important to know is that, your standard 1 to 2 and maybe up to 3 milligrams per kilo dose of succinylcholine will keep you in phase 1 block land. Whereas if you've given repeat doses, 3 to 5 milligrams per kilo, you creep into this phase 2 block land. What are the issues with this phase 2 block? Well, it's unpredictable. It lasts quite a long time. If you're trying to maintain paralysis with succinylcholine, you see a degree of tachyphylaxis, because remember, these receptors have shut up shop and they're not bothered. So you need more and more sucks to try and bind those receptors that are active. So it becomes quite unclear as to where you are and if you can actually maintain paralysis. And as you might expect, we see sucks apnea in patients. We've given them 1 to 2 milligrams per kilo. But if you've got someone who has reduced plasma cholinesterase activity, either because they're in that small group of people where it lasts a little bit longer, or pregnant ladies, or those with liver disease who aren't producing as much plasma cholinesterases, there you might find yourself in a world where your succinylcholine dose number 2 lasts a really long time. One of the reasons why succinylcholine infusions for paralysis are not modern practice at all. So, can we do anything about how long it lasts? Can we give any drugs to fix this problem? First things, what happens if you give rocuronium to someone who's in a phase 2 block? Well, you've just paralyzed them more, because those receptors that were amenable to being blocked now have a competitive blockade courtesy of the rocuronium. What happens if you give acetylcholinesterase to someone in a phase 2 block? You might see a degree of reversal as you've bobbed up the acetylcholine concentration in the neuromuscular junction. So it might push you away from being in a phase 2 block. But if you were to give neostigmine to someone who you'd just given succinylcholine to, you would actually extend the effect of that blockade, because you've now introduced more acetylcholine into the neuromuscular junction, with the suxamethonium floating around in it, it's going to bind to the odd receptor that the suxamethonium is not bound to, depolarizing that receptor or causing it to open, allowing sodium in. So neostigmine will make suxamethonium work longer in a phase 1 block. It all gets a bit spooky and mischievous, and this is why. Everyone just reaches for rocuronium these days. Suxamethonium, loads of side effects. The only benefit is it is very fast in onset and pretty fast in offset. But if they ask you in the exam, what are the side effects of suxamethonium, doctor? You need to be able to list a reasonable number of them. What are they? You should be able to shout them out right now. And I'm going to give you a few moments to think through the side effect profile of suxamethonium. Right, bad side effects of suxamethonium. Malignant hypothermia, bad news. Sux apnea, also problematic. And anaphylaxis, very challenging. Less problematic but still could give you the heebie-jeebies. Randomly causes significant bronchospasm that might mean that you feel like you can't ventilate the patient and think you're in the esophagus. Causes significant myalgia and muscle aches in patients who are poorly innervated in their musculature, courtesy of muscular dystrophy or significant cerebral palsy, or those who've been burnt more than 48 hours ago with increased extrajunctional nicotinic receptors. You will cause a life-threatening hyperkalemia when you give suxamethonium. It can raise intraocular pressure and intracranial pressure. Repeat doses cause bradycardia, especially in kiddies. Generally, all around, not a great drug. So remember, in summary, a phase 1 block is that straightforward, depolarized block where you might see a twitch, but it's just going to be the same amplitude every time as that block recovers. Phase 2 block develops with prolonged or repeat suxamethonium doses, and I think it's important to make a distinction that it's not really the same sort of block as that purely driven by neuromuscular blockade, because it's less predictable, causes weird mischief, behaves in a strange manner. I'd differentiate them in your mind. Phase 1 and Phase 2 really pertain to how suxamethonium behaves. That transition from Phase 1 and Phase 2 is dose-dependent, can happen quite suddenly, and coincides with tachyphylaxis I. They become less responsive to the paralysing effects of suxamethonium. Phase 2 blocks can be partially antagonised with acetylcholineesterases, whereas Phase 1 blocks are potentiated by cholineesterases. And if in doubt and anyone's really trying to drill you down on the pathophysiological basis of a type 2 block, say, no one really 100% knows. But we know that it desensitizes the nicotinic receptor into a closed state with a suxamethonium molecule still bound to it. Oh, how exciting, Pancuronium. That's done. It was pandemonium with Pancuronium. I should have probably got that in at the start. But you've done it, you've listened. We're all flabbergasted that 21.9 milligrams per kilo of oral Pancuronium can indeed paralyse a mouse. But we're not going to go out and do that. But we've learned something vitally important. I hope you enjoy the next 2 weeks pondering such mysteries. And next we're going to do reversal. So that's neostigmine and glycopyrrolate and scabidex. You've been listening to Gas, Gas, Gas. This was James waffling on. Have a lovely weekend. Cheerio and goodbye. Ahoy, Team Anaesthesia! You've survived yet another episode of Gas, Gas, Gas. Now, if you found it useful or harrowingly awful, please like and subscribe, drop us a star or 12, and follow with whichever podcast platform you find yourself using. Please leave a comment or ping off an email if you think I need to square something away. Now, there are a bunch of ways to support the costs of Gas, Gas, Gas. From buying me a coffee, to venturing forth via an affiliate link, to the horde of joyful SBA questions from Teach Me Anaesthetics. Those links are on the website and in the show notes. Speaking of website, definitely check out gasgasgas.uk for the show notes, diagrams, details, the references. Now, we all know, guys, that this is a bucket of content to consume, and it is like drinking from a fire hose. So I want to finish by saying, take it day by day, don't overcook yourself, don't freak out, and keep studying.